This is again a very important program which is on oxygen. Now, we all think it's a very basic thing, but we all know it's very, very important. And we have important lectures on oxygen therapy, the lifeline must to know, and oxygen and airway for the little ones, a little different to do. These two topics are going to be covered by very eminent faculty. The first topic, which will be the oxygen therapy, the lifeline, the speaker and the moderator today is Professor Rakesh Garg. We all know him very well. He is the professor at the AIIMS, New Delhi. He is a professor in onco-anesthesia, but he also has a keen interest in airway, and he does a lot of research, cancer pain and palliative medicine. And he has awards, innumerable awards and publications, and it's a real honor that he is with us in the ICA. Our second speaker, who's talking about the little ones, a little different to do of oxygen therapy, is Dr. Jensen Doctor, who is a faculty who is very well known in the ICA, and we see him very often participating as a faculty. He is professor and consultant anesthesiologist at the Homi Bhabha National Institute, Parel, Tata Memorial Hospital. His areas of interest, in addition, are, of course, the difficult airway and pediatric. So it will be a combination of the two that he will be talking to today. Again, several publications, book chapters, guidelines, and awards in numerous. So with this introduction, I'd like to request Dr. Rakesh to take over so that we can start the webinar. Thank you very much.
Thank you so much, ma'am. Thank you so much for the kind words, and thank you to you and Dr. Radhakrishan to invite us for this interesting and very popular series of webinars from the Indian College of Anesthesiologists. Today we'll be taking two sessions consecutively on the oxygen therapy. So as Madam rightly mentioned that though oxygen looks very innocuous agent, some says it's a gas, some says it's just the atmospheric constituents, but also we need to understand that this is the lifeline, and this just not should only be considered as gas or one of the component of the atmosphere, but this is also a drug. As for all the drugs, they require appropriate dosing, appropriate indications, and how to give to the patient so that they are delivered the way we want. In the same way, oxygen is also a drug, and we need to understand the various aspects of it. So that when we ask that this is a lifeline for somebody, yes, it is a lifeline. If we have to use it appropriately, we have to use it after understanding the various nitty-gritties of the oxygen. And once we start using it like a drug, I'm sure it will be beneficial in both the aspects, whether we say for the adult patients or whether we say for the pediatric age group, with Professor Jason, our doctor, will be discussing subsequently, and we need to understand it. I bring greetings from my institute. Now, when we talk about the oxygen therapy, we know that the patients, when they inhale the atmospheric air, they have only 21% of the oxygen to it. And as it goes down inside the body from the atmosphere to the airways to the lungs, the partial pressures of these oxygens will try to break down. And when we want to give oxygen to these patients for whatever indications, we want to increase these partial pressures in all the components. And this is what simply you can frame as oxygen therapy. And you all are aware of the oxygen cascade. As we go down, there will be various phenomena like shunt fractions, dissolves, there will be mixture of some other gases into it, and the partial pressure of oxygen from the atmospheric pressure to the mitochondria will start decreasing. And the reason may be because of the uptake of this oxygen or the consumption of this oxygen, or it also depends upon other physiological and pathological parameters also, which may be related to shunt, the hyperventilation, the cardiac output, the hemoglobin, the dead space in these patients. So variable factors will affect the partial pressure of oxygen when we talk of this oxygen cascade. And finally, we are looking for the mitochondria. We want that oxygen should reach and metabolism should happen for which oxygen is required. And in this cascade, if there is any issue anywhere in between, then the patient's mitochondria will not get the oxygen and they will start functioning abnormally to a certain extent in the beginning, something called as anaerobic metabolism. But subsequently, they will stop working. And this is where the cellular damage will start happening, or you can say hypoxygenation starts happening. So to prevent this, we need to understand this cascade, and we need to understand that how, if there is some abnormality in this cascade, how can we supplement it once we identify that there is some issues at this cascade. And this requires the supplementation of extra oxygen, which may be titrated as per the patient's requirement, and that requires the use of appropriate oxygen delivery devices so that a sufficient amount of oxygen as per the requirement of metabolism at the cellular level can continue. Now, when we say the tissue hypoxia, it could be at the level of the arterial hypoxia, it could be reduced oxygen delivery, or it could also be related to the excessive or dysfunctional tissue utilization. And I just mentioned that the regions could be many. So when we are using the oxygen as a drug, so it's a normal dictum in the medical sciences that once we are identifying the pathology, patient needs to be supplemented for it. And simultaneously, oxygen is not going to cure the underlying pathology. It is giving us some time so that the underlying pathology can be corrected through variable measures. And hence, once we start identifying these regions or etiology for tissue hypoxia, we can always treat the underlying cause, but for this time frame, so that the cellular hypoxemia or cellular hypoxia is not happening, we can supplement this oxygen. So we are using two words, hypoxia and hypoxemia. Hypoxia is basically lack of oxygen at the tissue level when we're talking the metabolism. Hypoxemia is just the content of oxygen or lack of oxygen in the blood level, arterial blood. So this is how you usually define the two terms, hypoxia and hypoxemia. Hypoxia is a result of hypoxemia, you can say in a very broader language. And the definition has been different for adults and pediatrics. Pediatrics, Dr. Jason will be taking a little later. Now the first question is, who are the patients or which are the patient profile who requires oxygen therapy? I just mentioned that oxygen is a lifeline. When there is any dictum or any dilemma that there could be a possibility of oxygen not being delivered to the mitochondria, we can always give oxygen, think for the underlying cause, and then titrate and wean off the oxygen as per the requirement. So you need oxygen for anesthesia practices, where during the airway management, or if some mishap happens during the intraoperative period, you need to supplement the oxygenation. You also need oxygenation for patients in the post-operative anesthesia care unit, in the intensive care units, in the patient who are recovering in the wards, and also in the emergency situations when these patients comes because of various medical and surgical emergencies, where you need to give them like a drug to begin with. And once you identify the reasons, you can always titrate them. And the reason is very clear that why we want to give oxygen to these patients, because we know that when we are inhaling or inspiring the atmospheric air, it is around 21% of oxygen that goes inside, that goes into the lung, into the functional residual capacity of the lung. And this is the only store that remains in our body. But when we try to give oxygen to these patients, depending upon how much fraction, how much flow we are giving, this nitrogen can be replaced with oxygen. And that's why sometimes pre-oxygenation is also called as denitrogenation, because we are replacing the 78% of nitrogen with oxygen, making it almost 100% oxygen in the lungs. And that is where, if some mishap happens, we are increasing the reserves of these patients so that they can tolerate any of the event that could have happened, say during the airway management. If we are not able to secure the airway, this 100% oxygen reserves in an increased amount, which can be from 450 ml to 3000 ml, will give us more amount of apnea duration and a safe apnea duration for these patients. Similarly, once we want to deliver this, we understand that it is helping, but then we need to understand 4 different aspects. One is the technology, then the tools to deliver it, the techniques that we want to follow for a particular patient. And there are always some strategies or evidence which are coming up, which we need to incorporate to use drug as a lifeline, to use oxygen as a drug, and to save our patients. The basic purpose remains the same: maintain oxygenation, prevent desaturation, and sometimes we resaturate in case the patient becomes desaturated. And that's why we have to use all those technologies. And when we say that during the perioperative care, or you can more precisely say during the airway management, initially to begin with, we were talking about the pre-oxygenation, which was a stop-start approach. We shifted to para-oxygenation, but now to avoid this old terminology, we say just oxygenation. So during the airway management,
don't cross.
With the oxygenation supplementation to all our patients so that we can increase the body reserves. And this can be done with various methods, which will come a little later. In the postoperative anesthesia unit, ICU and wards, you need to look for these patients, try to identify the hypoxia that is happening in these patients, and you can easily find out the physiological changes or variable parameters that change in these patients to look for the symptoms of hypoxia. And simultaneously, always you need to monitor them also. And you can have various laboratory assessments, starting with the pulse oximeter, the mixed venous oxygen, the arterial oxygenation, serum lactate levels. So these are the various parameters that will give an indication of hypoxemia happening at the tissue level. Now, how to go about in these patients' management who are in the post-operative wards or the emergencies? This is one of the important guidelines which can guide us for supplementing oxygen. But remember, I just mentioned that oxygen is a drug. So whenever we give drug, we have an target. We don't want that it should be given without control, without limit. And that's why we say that we need to have an end target of the pulse oximetry readings. Acutely ill patients, we accept up to 94 to 98%. Those patients who have respiratory disease, even 88 to 92% is acceptable. And we have seen during the COVID-19 pandemic also. Always remember, as drug, oxygen should also be recorded, the flow should be recorded, the FI should be recorded, and its impact on the patient for which it is being given, that is the response, should also be recorded so that you can titrate the oxygen as per the patient requirement. Now, these are 4 groups of patients that would require oxygen supplementation. Let's see one by one how to go about and provide these 4 categories of patient the oxygen therapy. Those patients who are critically ill, they require high levels of oxygen to begin with. For example, patients with cardiac arrest, patients with septic shock, you start them on a high flow oxygen 100% with reservoirs at high flows. And then subsequently, you can always adjust, titrate once you have started treating the underlying condition, and then you can continue using it. But then you have to monitor it. The second group will be seriously ill hypoxic patient. You may not be requiring so high flow or FI. These patients probably 2 to 6 liters, or maybe if patient is not responding, up to 5 to 10 liters. Using various face masks can be given to these patients, like in those patients of acute asthmatic attacks, the acute heart failure, embolism. By the time you start treating them, and then you can always titrate these oxygen and wean them off. The third category will be for which you should be monitoring closely. Oxygen may not be required unless there is indication from the clinical symptomatology or monitoring to be patient to be hypoxemic. Like, for example, say patients with the renal shutdowns, the CKDs patients, some poisoning, patients with stroke. Here you can start them on a low oxygen flows using nasal cannulas or simple face mask, and then titrate as per the patient's requirement with pulse oximeter as the endpoint. The last category for patients will be those with respiratory issues like COPDs. Now, these patients may come up with the risk factors of hypercapnic respiratory failure. You cannot give them a very high flow oxygen from the beginning. That's why you start with some controlled oxygen delivery to these patients so that you can give and control and target your saturation to 88 to 92%. And once you have monitoring, you can further titrate your oxygen supplementation to these patients as per the requirement. And once you are monitoring it, you have to wean them off. Once the patient becomes clinically stable, underlying disease has been taken care of, the saturation is more than the target range, try to wean them off gradually with 1 to 2 liters, downgrade. How to do it will come a little later, and then you can stop and observe them for after they have been weaned off. They need monitoring. They also need monitoring the etiology for which these patients became hypoxemic or hypoxic has already been taken care of. You also need to be managing these patients. So to summarize for you, you can always use this type of up and down titration of the oxygen to these patients depending upon the requirement which I have just mentioned for you. You can go up and down, titrate, have an endpoint, and use your oxygen as a drug appropriately as per the patient's requirement. Now, also we need to understand it's just not the oxygen which can, using various gadgets, you need to go up and down. But sometimes those patients, especially like in patients with emergencies or intensive care unit, they may be having respiratory pathologies and they may not be responding well to the various oxygen delivery devices which we conventionally use. And also that's why we should be always ready that oxygen therapy is just not the delivery of oxygen through the oxygen delivery devices like face masks or nasal cannulas or reservoir masks. Sometimes we also have to go ahead if the reason for hypoxia or hypoxemia is the ventilatory aspect also, or there is pathology in the lung, we have to deliver using certain parameters which may require the use of non-invasive ventilation or at times invasive ventilation also to these patients so that the oxygen can be delivered well to these patients. Now, what systems do we have? We have mentioned that we have to titrate, we have to use them as a drug. So what systems do we have? Now, it all depends upon the patient we have seen, and accordingly, we can just divide them normobaric versus hyperbaric. Normobaric, they could be low dependency, medium dependency, and high dependency. And low dependency, usually we devise these oxygen delivery devices as variable performance and fixed performance. The fixed and variable, it is based primarily on the predictability and consistency of the FiO2 which is being provided by the oxygen delivery devices to a particular patients. So the fixed performance devices, the system provides all the patient's inspired gas, and hence whatever you have set there will be delivered and FiO2 will remain stable even if the patients try to hyperventilate or take a deep breath. On the other hand, variable performance oxygen delivery devices, they provide some of the inspired gases through these devices and rest of the air is taken from the surrounding air. And that's why their delivery will vary depending upon the patient's performance. And hence, when we talk about these devices, the variable performance, they are patient dependent. This means fixed performance, patient independent, and they are usually high flows. And then we can further divide variable as no capacity system, there is no rebreathing, and capacity system, chance of rebreathing. Fixed performance devices, we use ventimask, anesthesia circuits, and now even if you say think about the Thrive and all those equipments may also be a part of it. But remember, when we talk about these devices, the high flow and the low flow devices, or with the reservoir devices, you can easily say that the patient flow is going into these patients at a certain thing, but the device flow will decide that how much patient will be taking air from outside. So if you talk about the low flow devices, at a certain stage, patient will be taking oxygen or air from the surrounding area. But if you're using high flow devices, then the whole oxygen is being supplied by the device itself. If you're using a reservoir, it will act like a reservoir of the oxygen to be delivered to the patient when patient want it, and hence its performance will change and they will be delivering whole oxygen, though they may not be high flow, but since they have a reservoir, the total oxygen will be supplied by the device to the patient as and when required. So this is the beauty, and that's we need to understand that why do we need a gadget of armamentarium of the oxygen delivery devices into our oxygen therapy management. We are not okay with just one or two devices. We have to all, and this graph shows the importance that why should we have nasal cannulas, nasal catheters, oxygen reservoirs, ambu bag, and so on and so forth for the delivery of these devices. Now, what are the variables that leads to the alteration of the various oxygen to variable patients? One is obviously the oxygen flow rate, the patient factors, inspiratory flow rate and the expiratory time, and also the device factors. So I already talked about all those factors till now. So this is just the summary that these are the determinants, these are the variables that will make you understand that which patient would be okay with a particular device. And hence, sometimes we need to change from one device to other to get the benefit or get the end point where we want that patient should be appropriately getting oxygen at the mitochondrial level. So this is what I have just talked about you. This is what the summary is. The low dependency, low flow system, high flow venturi, HFNCs, low flow nasal cannula, simple mass, reservoir mass means partial rebreather and prone breather. So these are the various equipments, and all those equipments of oxygen delivery devices should be available at all your places when you want to give oxygen therapy. So it's very clear that nasal cannula is not a substitute of simple base mask. It is not a substitute of reservoir. It's not a substitute of machinery. So we need to have all so that we can give it. This is the nasal cannula. I may not be going into details about it. You must have seen it. It can give various FI at various flows. Nasal catheters can give up to 45% of FI, requires up to 8 liters of flow. Transtracheal catheters, 4 liters, up to 35%. Face mask, where you can see the exhalation ports. It acts as a small reservoir of 100 to 250 ml. It can deliver FI up to 0.6 depending upon flow of 5 to 8 liters. Partial rebreathing, where it has a reservoir capacity of around a liter. It can go further high of FI up to 0.8 with a flow of 10 liters. And if you move further on, a non-rebreathing mask, where you can see there is a one-way valve attached on the face mask. It is tightly fitted, and it can further increase the FI even up to 1, but at 15 liters per minute. So you can see the arena of these, where the FI from 0.3 to 1 can be given through various devices, and hence we need to choose our devices. Now, once we want to titrate the oxygen, give them as per the patient requirement. The venturi mask, which comes into two types, a fixed model and a variable model, but both works on venturi principles. They can be used like in patients with COPD. These can deliver FI from 0.24 to 0.6, and accordingly flow will change. Higher FI, more flow, and they are measured. And usually each one of us know, for this will be important for postgraduate students, that the Bernoulli effect and the venturi principle is the guiding principle, that how the air or the surrounding atmospheric air is entrained at particular flows leads to dilution, and hence the target oxygen of FI is delivered to these patients. We also need manual resuscitator. People think that this is only for resuscitation manually, but remember, it can be used for both spontaneous and assisted and controlled ventilation as well. So you can use it, and since this also has a reservoir attached to it, at high flows of 15 liters, you can even deliver up to 100% or FI of 1 to these patients. High flow nasal cannulas, you all have seen it during the COVID times. These has become very popular now, and these are bringing the oxygen therapy to a different stage where we even can avoid mechanical ventilation or non-invasive ventilation to a certain time by the time we are managing the underlying etiology. Now, coming to the anesthesia practice, what's the role of oxygen is? Now, during the airway management, we need to remember, earlier we used to say pre-oxygenation, then we used to say para-oxygenation, but now we say oxygenation. So oxygenation should be given to all the patients during the airway management, because there may be situations of unanticipated difficult airway with high morbidity and mortality. And hence, it has become a dictum that all patients must receive oxygenation during the management of airways, whatever, whether difficult or not difficult. Now, there are various tools and endpoints that needs to be considered when we are talking about pre-oxygenation. The conventional tools were 3 minutes with tidal breathing, 4 vital capacity breath for 30 seconds, 8 vital capacity for 60 seconds, 4 acceleration followed by tidal breathing. Pre-oxygenation is more effective, and this has been conventionally used as a method of oxygenation during the airway management in the operating room. But remember, earlier we don't have a tool for it. And now when I say 3 minutes, 30 seconds, 3 minutes of tidal breathing, we do not know whether effective denitrogenation has happened or not. I mentioned in the beginning that we have to replace 78% of nitrogen with oxygen to say that complete denitrogenation has happened. But how can we know about it? Now we need to use the equipments or the monitoring tools that we have. We can either monitor the end-tidal oxygen or the end-tidal nitrogen. If the end-tidal oxygen is more than 90%, as you can see in this picture, it is around 86%, or the end-tidal nitrogen, which is available in certain equipments, certain machines, if it is less than 4%, we can comfortably say that majority of nitrogen has been removed and replaced with oxygen. Now, we are moving towards a more important gadgets, especially when we expect that these patients would be having some issues or some pathological changes. We can have conventional flows up to 15 liters, but now, as in the COVID time, we can see that we have high flow nasal cannulas, which can even deliver flows up to 60 to 70 liters. At places where these are not available, you can use combination. Most of the anesthesia workstation of the operating room have 2 oxygen sources. Each will deliver 15 liters. And you can always use a combination of both, a dual mode of oxygen supplementation, increasing to up to 30 liters. So this is what you can use for majority of your patients. In addition to it, some of the patients, when we talk about those patients who are having respiratory pathology, they may also require CPAP. We know that CPAP of 5 to 10 centimeter will decrease the shunt fraction, will increase the FRC, and this has been used in oxygenating modalities, especially like bariatric patients, patients with sepsis requiring emergency surgeries, and at times even the pressure support ventilation using a face mask or even supraglottic airway devices has been used as one of the modality of oxygenation during the airway management. So I think we have a lot of armamentarium for oxygenation, and all patients should receive as per the patient requirement. Also, we also need to understand that it's just not the equipment or the oxygen delivery. Patients should also be able to capture and utilize those oxygen in a more effective way. And for this, we also require patient positioning. We know that if an obese patient lies supine, there will be splinting of the diaphragm, there will be collapse, there will be atelectasis, and hence we also need to understand the role of optimal position as a part of the oxygen therapy. Patient may be head up, maybe ramp, at times even lateral position also required for giving them an optimal position for an optimal oxygen delivery so that patient FRC increases. So to summarize once again, we were following the stop-start approach earlier, where we used to give oxygen, we used to manage the airway. If patient desaturates, we resaturate again. But this concept is no more now. What we want is, we want to extend the apnea period. All patients should receive not only pre-oxygenation, but also the apneic oxygenation, or in a simple language, we can say all patients must receive oxygenation throughout the airway management. And that's where the role of apneic oxygenation also comes in. We know that if we give a high flow oxygenation, the passive diffusion of the oxygen will happen across the alveolo-capillary membrane, and these patients will be sufficiently getting some amount of oxygen in line with the oxygen gradient at the alveolo-capillary interface, and their apnea period, or you can say safe apnea period, will increase. And you can use various equipments that are available for providing apneic oxygenation. Try an additional tool where you just not only combines apneic oxygenation, but it also leads to the formation of a CPAP, and there is always some amount of gaseous exchange in a flow dependent dead space flushing, and hence these provide not only oxygen but also to a certain extent wash out the carbon dioxide from it. And this tool, all of you have seen it quite commonly during this COVID-19 pandemic, so I may not be going into detail. But remember, this pathology, if you understand, when you give thrive to these patients, there will be dead space flushing, there will be mass flow of oxygen that will just not deliver oxygen across the gradient, but also it will help the carbon dioxide clearance. And that's why it just not increase the safe apnea period, but it also prevents the side effects that can be accumulated in an extended apnea period due to hypercapnia. It can be used for various purposes. Now they have advanced modalities. It provides patient comfort, the humidification, the positive air pressure, the carbon dioxide clearance, and also it maintains temperature. And the drying of the mucosa does not happen with this, and that's why this has come an important role, and it can even deliver up to 70 liters, increasing the apnea time. We don't need to know the strategy of using it. We start at low flows. Once the patient goes into anesthesia induction, we gradually increase it. Patient tolerates it better, and then we can go out and do airway management. And this has found a role into various procedures now. This is just not airway management. We are doing many of the outside the operating room procedures now, and this has found an important role. Now, having said that, I said oxygen is a drug, oxygen is a lifeline, should be used. But are we having some evidence? Yes, there's sufficient evidence across the globe where all the airway management guidelines, more than 10 to 12 professional societies have made it, and everybody has mentioned that the maintenance of oxygenation is important. And they have already emphasized that each step of the airway management, patient must receive oxygenation through various modalities. We have already discussed various gadgets are available. We have always discussed various strategies are available, like use of NIVs, CPAP, Thrive, etc. And hence all those modalities should be used during the airway management so that patient remains ventilated, if not at least oxygenated, in case if we are facing a difficulty in airway management. Same will be applicable even for intensive care unit where critically ill patients at whatever steps of airway management give oxygen to these patients, increase the safe apnea period, prevents hypoxic injury, and you are able to manage. Coming to the last few slides, I just have discussed about the normobaric oxygen therapy. As anesthesiologists, we should be little conversed about the hyperbaric oxygen therapy, which we have used, I have used for a certain time while at was RML Hospital in Delhi. These hyperbaric therapies are available at various centers in India, where the oxygen is delivered at more than normal atmospheric pressure, 1.5 to 2.5 atmospheric pressures. And there could be a monoplace chamber, which only one patient is there in the chamber, or there could be a multi-place hyperbaric chamber in which a large chamber of a room size and multiple people can sit inside it. It has been used for various pathologies like radiation injuries, skin grafts, bone infection, carbon monoxide poisoning, decompression sickness, air embolism, burns, infections, gas gangrene, and it has found various beneficial effect in these patients. The recovery becomes much better if we give them oxygen therapy at more than 1 atmospheric pressure. Now, having said that, people are usually concerned with the oxygen toxicity. I've heard many times where they say if you give oxygen for say 5 minutes, 3 minutes at 70 liters, patient will get oxygen toxicity. But remember, the oxygen toxicity do happens, I agree, to the lung and CNS, but the determinants of oxygen toxicity depends upon two. One is the partial pressure of oxygen, and second is the exposure time. And exposure time is when you give oxygen, if it is more than 24 hours, then the oxygen toxicity will start happening to the CNS and lung primarily. Most of the time when you do it for airway management or for acute event, we expect that in a couple of minutes, you will be able to manage the situation, and hence this high flow oxygen will not be required for extended duration of time. But yes, if for some reason it is required, look for the CNS toxicity and pulmonary toxicity. If they start happening, then you need to think of other modalities of decreasing the oxygen requirement in these patients and try to treat it. So to summarize from the today's talk, oxygen should not be given. It is a drug. It is a lifeline. It should be prescribed as you do for other medications. You mentioned the dose, you mentioned the route, you mentioned the flow rate, you choose appropriate delivery devices for it, and you also monitor it as you do for other prescriptions. Knowledge of design and performance of oxygen delivery is essential because one device is not interchangeable with other device. Each oxygen delivery device has its own importance in the effective and optimal delivery of oxygen. Patients should be appropriately monitored as you do for other drugs prescription. Your target oxygen saturation is not 100%. It should be as per the patient requirement, 88 to 90% for COPD patients, or maybe around 94, 93% for other patients. It is not 100%, but simultaneously also look for the patient's effect of hypoxia happening in these patients. The overall course patient should also be documented because oxygen is not the treating of the pathology. Oxygen is giving you some time so that you can treat identify and treat the underlying pathology. So it allows us to buy the time and thus to prevent the hypoxic injuries to the mitochondrial or the cellular level. And for this reason, patients should be documented, identify the etiologies, manage them, and then accordingly you can titrate, wean the oxygen for the patients. So thank you so much. And now in continuity, I will request Dr. Jason, our doctor, to take it forward. We know that the little ones are not the half adults or quarter of adults. They're absolutely independent, individual creature in this world. They have their own identity, they have their own requirement, and they are special for us. And for this, we have a special person with us, Doctor, who will be taking the important aspect, how to do different for our little ones. Over to you, sir.
Thank you so much for giving me an opportunity to be a part of this academic initiative. So Dr. Jayashree Madam, Dr. Radhakrishnan, and Dr. Rakesh, and thank you for the excellent talk on oxygen therapy. So I will begin my talk, and I will be talking about, my slides are visible, right?
Yeah, visible, sir.
Yes.
Yeah. So I'll be talking about oxygen and airway management for the little ones, a little different to do. So we heard Dr. Rakesh's excellent talk and overview on what exactly do you understand by prescription of oxygen and what are the different techniques, what are the various endpoints. But like you all know that pediatrics and children are a special subpopulation, and we'll come to during the course of my talk as to why they are different and what is so special about them. So what makes the pediatric airway different from the adult airway? So coming to the basic anatomical differences, that children have a large floppy epiglottis. This is, they are omega shaped, so they are very prone to any form of edema, any croup, any upper airway obstruction. They have a relatively large tongue with respect to the oral cavity size, as a result of which there is upper airway obstruction due to tongue fall, and you have to give the right amount of pressure and open the airway well. Apart from that, you have a highly placed laryngeal position. So in the larynx is at a higher level of C2, C3 vertebral level, and they have a prominent occiput. So as the child grows, the proportion of the head changes so that the occiput becomes relatively smaller, or rather the growth is relatively all over the circumference of the head. It grows to such an extent that the neck flexion, because of the enlarged prominent occiput, gradually reduces. That is why in infants, it is always described in literature that you need to put a shoulder roll rather than a head ring or a pillow under the head to minimize the neck flexion. Otherwise, when the neck is flexed, you will not get the airway that is opened, and there will be minimal space, and the neck will continuously be flexed, making an already existing airway even more difficult to ventilate. So in infants, it is recommended that you place a shoulder roll under the shoulder blades, okay, so that the tragus is in line with the anterior part of the humerus. In small children, you may need not place anything under the head, and in older children or adults, it is described that you need to place a pillow or a head ring so that you have the optimal sniffing position for the laryngoscopy, or in obese individuals, you need ramp position with a backup, which was adequately described by Dr. Rakesh. So these are some of the anatomical differences that are there in children. Coming to the physiological differences, which are much more complicated and much more relevant in terms of they have a compliant chest wall. So after induction of anesthesia or under sedation, there is a loss of upper respiratory muscle tone, but also loss of intrinsic muscle tone, as a result of which the functional residual capacity decreases. There is atelectasis, there is rapid desaturation, the closing capacity is higher than the functional residual capacity. The work of breathing is higher, okay? Apart from this, there is an increased respiratory rate required than adults, because as you know, the oxygen requirement is much higher. So there is a high rate of oxygen requirement and lesser reserve. So there is a shorter apnea time to desaturation. They desaturate very quickly. They don't give you a very good apnea margin. Apart from that, there are decreased type 1 fibers. So these type 1 fibers are prone to resist, they are extremely resilient, and they are resistant to fatigue. So when you have a decrease in these type 1 fibers, the remaining fibers that are there of the diaphragm and the respiratory muscles, they are prone to fatigue and respiratory failure. So when you have airway trauma or crew or increased airway instrumentation because of the edema that occurs with the upper airway in the form of crew or because of trauma, because of bleeding. So there is a Hagen-Poiseuille's law. So resistance is inversely proportional to the fourth power of its radius, right? That is what is described in physics. So this is more relevant in children because as the radius decreases, the resistance to breathing increases. Okay, and they tire out and they're very prone to fatigue. And in addition, there is a higher oxygen consumption. Also, in airway instrumentation in children, they have a higher predominantly higher parasympathetic tone, as a result of which they're extremely prone to develop bradycardia or cardiac arrest in response to any airway instrumentation or hypoxemia. So these are some of the physiological differences and anatomical differences in children. In addition to this, airway management procedures all need to be performed under general anesthesia or deep sedation in infants and children. No child is going to allow you to do an awake fiber optic intubation or an awake airway technique, and they are not going to be very happy to come with somebody who's not known to them, not a familiar face, into the operating room. So you need to sedate them to avoid separation anxiety. You need to have parental presence inside the operating room. You need to put them to sleep before you attempt any airway instrumentation. Okay. Apart from that, the size constraints are very particular for different age groups and different ages of the child population, pediatric population. In addition, they give you less apnea time, okay, because of high oxygen consumption, rapid desaturation. If you're an occasional pediatric anesthesiologist and not very comfortable with babies, you are already jittery with your adrenaline peaking and you lack the experience to manage a pediatric airway. So that makes matters even more complicated. And children, most of them will be school-going age and will have some form of upper respiratory tract infection or the other, which is why they are more prone to develop laryngospasm or post-intubation stridor or edema following any airway instrumentation. Okay, so in a lighter plane of anesthesia or with increased secretions due to upper respiratory tract infections, they are prone to develop laryngospasm for when any painful procedure is undertaken in a lighter plane, or there are increased secretions which are going to trickle down and stimulate the larynx. So these are some of the differences that are there in the pediatric subpopulation. Okay, so like Dr. Rakesh mentioned earlier about the guidelines, so we've come out with these pediatric airway guidelines by the All India Difficult Airway Association in 2016, and they actually, I will take you through each step and why there is oxygen is important at each step and what are the differences. So coming to the first step, that is optimizing bag mask ventilation, laryngoscopy, and intubation. What is different in children? So the prerequisites to laryngoscopy and intubation are, before any form of airway instrumentation in the form of laryngoscopy, an IV access must be secured. So most of these children will need to have an inhalational induction, or if you are anticipating a difficult airway beforehand, if they are syndromic, you need to apply EMLA cream, and with parental presence, you need to secure an IV access if the airway is anticipated to be difficult. If the airway is not anticipated to be difficult, you could have parental presence during induction, and you could probably take them under with an inhalational anesthetic and secure an IV access. Appropriate monitoring in the form of ECG, pulse ox, non-invasive blood pressure, capnography should be made available. Pre-oxygenation. We all heard Dr. Rakesh talk on pre-oxygenation and the importance of filling the oxygen FRC and the entire total lung capacity with oxygen, giving you a larger oxygen reserve. So your time to apnea, during the course of my talk, I will talk on what is the importance of time to desaturate in children. Apart from that, adequate depth of anesthesia, analgesia, neuromuscular blockade. Like I told you earlier, they're extremely prone to develop laryngospasm, bronchospasm, because of hyperreactive airways, upper respiratory tract infections. So any form of airway instrumentation needs to be done with adequate depth of anesthesia and neuromuscular blockade. So nasal oxygen may need to be administered with nasal prongs or catheters during attempts at laryngoscopy and intubation. for apneic oxygenation. Use of correct size of equipment is a must. You don't want to be struggling with a larger mask or an incorrect laryngoscope blade or an incorrect size endotracheal tube in a child who's prone to develop airway edema because of trauma. So your first attempt has to be the best attempt. So coming to the first aspect, pre-oxygenation in adults, you can't have the fantastic pre-oxygenation of 3 minutes of pre-oxygenation or 4 vital capacity breaths and 8 vital capacity breaths. The simple act of restraint of the child when you are taking them under with an inhalation anesthetic is enough to cause the child to be thrashing around and not allow you to put a mask on the face. But you can hold the mask closer to the face and begin with a lower inhalational dial concentration and aim for the child to go under. And after that, you can mask ventilate these children. So that is a different thing that you have to do in children. You can't aim for a perfect end-tidal oxygen saturation, end-tidal ETO2 of more than 90% and ET-N2 of less than 4% before you begin induction of the. So induction and pre-oxygenation has to be hand in hand and has to be done simultaneously. So pre-oxygenation the child may not accept the placement of the face mask. There are various strategies done to mask the inhalational odor by having maybe lip balm and scented face masks and lots of things which are known to sort of help you in induction with the inhalational agent. And high flow oxygen can be administered by placing the mask as close to the child's face as tolerated to enrich the oxygen content or FiO2, what the child breathes before the induction. As soon as the child goes under and you have an IV access in place, you continue pre-oxygenating or para-oxygenating as it is called. You continue mask ventilating till you have an end-tidal oxygen of more than 90% and denitrogenation of less than 4%. And any airway intervention has to be done only if the oxygen saturation is more than 95%. That grows across the board for adults and children. So that is something that we've come to, that there is an endpoint given that you stop any airway intervention and resume mask ventilation if at any point of time your saturation dips to less than 95%. Now, optimizing face mask ventilation in children. What is different in children? So you meant any anesthetic has to have adequate depth of anesthesia before you do any airway instrumentation. Upper airway, like children have buccal pads of fat. The upper airway is a lot of soft tissue and fat pad, which is likely to, if you use too much force, you will displace all of this into the oral cavity, making an existing oral cavity, which is already narrow because of macroglossia and things like this, further narrow by causing more of force rather than gentle chin lift, right? So it has, all the maneuvers have to be gentle, and you have to make sure that you do not compress any soft tissue and compromise the oral cavity any further. The external nares should not be compressed. So the face mask fit should be adequate, and it should be fitting in such a way that you are not compressing the nostrils, or they are obligatory nose breathers. So you should not be compressing the nostril or airway in any form. The head has to be maintained in neutral position. You can use airway adjuncts, but again, whenever you're using airway adjuncts, the depth of anesthetic has to be ensured. You can use ventilation with 2% bag mask technique in case mask ventilation is difficult and you have a novice resident or a person who's relatively untrained in anesthesiology inside the operating room. Identify and treat laryngosspasms. Now, this is very important. If you're not able to mask ventilate well, you should have laryngospasm and bronchospasm higher up in your differential diagnosis list, because children are more prone to develop this in an already narrow larynx, right? So in a lighter plane, or because of some trickling of secretions, if the child develops laryngospasm, you're not going to be able to have a visible chest rise. So the treatment to that is you deepen the anesthetic plane, not with an inhalational, but with an IV induction agent. So you can give propofol, you can give 100% oxygen, you can give CPAP. In spite of all of this, if you're not able to break the spasm and cause a visible chest rise or ventilate the lungs better, you can give a muscle relaxant and aim to intubate, to bypass the larynx with an endotracheal tube, okay, so that you can oxygenate these children better, right? Again, when you are having a laryngospasm, or even when you are not opening the airway well, okay, it is extremely common to have gastric distension, because that is the path of least resistance. So if your upper airway is not patent and you're trying to aggressively bag mask ventilate, it may so happen that whatever ventilation you are giving is opening up the lower esophageal sphincter and the stomach is getting distended. As a result of which, this is something very, again, peculiar to children, that if you distend the stomach too much because of improper mask ventilation, or because of laryngospasm and gastric distension happening as a consequence of that, what happens is the stomach distends in an already existing low FRC. The stomach distends and pushes the diaphragm up further, causing splinting of the diaphragm, as a result of which the FRC reduces even further. So the solution to this is identify and treat laryngospasm. And if you suspect that there is a lot of gastric distension that has happened, you put a small bore of size nasogastric tube and decompress the stomach so that the diaphragm moves down and you can ventilate the lungs better. Okay, so this is something very different and peculiar in the pediatric population. Again, administration of the neuromuscular blocker, you should not hesitate to do that, because if you have to break the laryngospasm, if it doesn't get treated in time, you can have things like negative pressure pulmonary edema and things like that developing in children very fast and quickly without even you realizing, right? So do not hesitate to use a neuromuscular blocker if it is required, and deepen the anesthetic plane, give 100% oxygen, and bag mask ventilate to be able to see a visible chest rise. So this was about pre-oxygenation and optimizing face mask ventilation. Coming to the apneic oxygenation bit, that in the guidelines and all over the world after the COVID pandemic, apneic oxygenation has gained a lot of attention. Okay, so this was a term that was coined first by Dr. Richard Leviton, in which in trauma patients, he used to use nasal oxygen during effort securing a tube, or a no DSAT technique, which is the acronym used for that. So what it was, it's a very simple thing that after pre-oxygenating, when your apnea time is there, when you're doing a laryngoscopy or attempting to secure the airway with a definitive airway in place, either in the form of a supraglottic airway device or with an endotracheal tube, okay, you continue nasal oxygen with a nasal prongs, okay, put up, and you give high flow rates of oxygen to have a longer apnea time. So how do you do it and how does it help? I will come to in a moment. A few of the important physiological aspects have been covered by Dr. Rakesh as to how it works, but I will be re-emphasizing on those, because this is something which has changed the way we practice, and it has definitely been a new kind of a technique in our armamentarium. It used to be used, but it was not so commonly used. Now it's very useful, especially after the COVID pandemic. A lot of patients' lives have been saved after use of high frequency nasal cannula, and they've been it's avoided ventilatory care completely. So apneic oxygenation is merely an adjunct, and it is not a substitute for pre-oxygenation. So an important terminology here is, do not confuse between pre-oxygenation and bag mask ventilation and apneic oxygenation. Pre-oxygenation is before induction of anesthesia. Bag mask ventilation is after you induce anesthesia and give a muscle relaxant. Okay, and the time where you are performing an airway procedure and you are not oxygenating is apneic oxygenation, when it is given in the using either a Thrive machine or nasal prongs or nasopharyngeal airway. Okay, so these are some of the techniques. So how does it work? Like Dr. Rakesh described, that the carbon dioxide, this is for an adult. In children, it's similar, but you have carbon dioxide going into the lung at 20 ml per minute, and the oxygen consumption in an adult is 220 ml per minute. Because of this oxygen absorption, lesser amount of carbon dioxide entering the lung, there is a negative pressure. Okay, what happens is, because of this reservoir of oxygen happening, there is an aventilatory mass flow. Okay, so there is a zone of negative pressure over here, and because of which this negative pressure entrains the oxygen enriched upper airway oxygen into the lower airway. Okay, so this is how apneic oxygenation works. So the various techniques of giving apneic oxygenation in children is, you could use a standard nasal cannula, okay, and just put them as nasal prongs with a higher oxygen flow rate, maybe 0.5 to 1 liter per kilo of body weight. Okay, so that is what is recommended for standard nasal cannula. Again, it has to be humidified. You can use a auxiliary port on your anesthesia workstation or on the wall unit or on the pendant, and you can have a oxygen flow meter there, and you can put the nasal prongs connected to that. So this has to be done in addition to the bag mask. So that has to be from a separate auxiliary port or from a separate oxygen source. Okay. Apart from that, you can also have Thrive or humidified high flow nasal cannula with the machine that Dr. Rakesh showed you, that you have a Thrive machine where you can, if it is in the ICU, they have an oxygen blender where you can titrate the FiO2, but for Thrive, the FiO2 is always 100%. Okay. And that has a flow meter that you can adjust the oxygen flow up to 70 to 80 liters. Okay. So depending on the age and weight of the child, you can give 1.5 to 1 liter. So you can give, as suppose you have a 20 kilo child, you can give up to 20 liters through the Thrive machine. Another important way in which oxygenation can be done is you have a nasopharyngeal airway and you connect a endotracheal tube connector using this as a nasal trumpet. So this is a common technique that is used to do a fiber optic intubation through the other nostril, where you use this nasal trumpet and connect this to a JR circuit and continue inhalational anesthetic through that. So that is something which is inhalational technique, but oxygenation is continued and is maintained using other used for that. You can also have an endotracheal tube and continue spontaneous breathing. Connect the oxygen source to the laryngoscopy blade for the true view laryngoscopy. Again, you have channeled video laryngoscopes. So through the channeled video laryngoscopes, you can put through the channel, you can put a endotracheal tube and you can connect the endotracheal tube through high flow oxygen through the closed circuit. So that also serves in some form of oxygen delivery to the upper airway. Okay, and may help in some form of apneic oxygenation. So this was a very interesting study that was done and published in the British Journal of Anesthesia in 2018, where they used the Thrive and they compared 3 different arms. So after induction of anesthesia in children with bag mask ventilation, they used 100% oxygen with flow rates of 6 to 8 liters per minute. And they targeted an end tidal oxygen ETO2 of more than 90%. Saturation was 100%. And transcutaneous CO2 is what they used. And they targeted a transcutaneous CO2 of, because it was apneic oxygenation. So you were not ventilating and you wanted to know the CO2 level. So it was 30 to 40 millimeters of mercury. Once this was achieved, bag mask ventilation was halted, and they looked at the saturation, they looked at the transcutaneous CO2, and they randomized these children into 3 arms. Okay, so one arm of which received a low flow oxygen of 0.2 liters per kilo per minute, but the FiO2 was 100%. The second arm had 100% oxygen with 2 liters per kilo per minute of oxygen flow, and the third arm received only 30% FiO2 of oxygen and 2 liters per kilo per minute of flow. So here the flow was high, but the FiO2 was low, and in the other 2 arms had differing flow rates, 0.2 and 2 liters per kilo per minute, and FiO2 was retained to 100%. So when they analyzed this, they found that in the low flow arm with 100% oxygen and in the high flow arm with 100% oxygen, okay, the apnea time was 6.9 minutes and 7.6 minutes. High flow oxygen with kPa per minute without any difference in the 3 groups. So this is the box whisker plot in which they said that the median apnea time in the 0.2 and the 2 liters of 100% FiO2 was similar, but in the 2 liters flow rate with 30% FiO2, the apnea time was much lower. Okay, with the 25 to 75% and the range, and these are some of the outliers. So they found that there was no difference in apnea time between the low flow and high flow oxygen, 100, which was where the FiO2 was 100%. But in the groups receiving the 30% FiO2, it was much lower. So the extension of apnea time enhances safety in difficult pediatric airway management and may be useful for airway strategies. And you should, whether you use a low flow or a high flow, that is irrespective, but the FiO2 should be 100% is what this study found. And they did not find a rise in the transcutaneous CO2 when the apnea time was as high as 6 to 7 minutes in these children. So coming to the step 1 of the guidelines, at why I am coming to this is because at each point of time, we have stressed the importance of oxygen and what is different in airway management with laryngoscopy versus adults versus children. Okay. So here nasal oxygen is to be continued. The subsequent attempts or any instrumentation of the airway has to be done only when the SpO2 is more than 95%. We advocate giving only one more attempt of laryngoscopy after the failed first attempt at direct or video laryngoscopy, and then you need to change the device, the technique, or the operator. So if you've used a conventional laryngoscope, you can use a video laryngoscope, or another experienced operator can perform it, or the position needs to be changed. You can use external laryngeal manipulation, use a bougie stillet. So don't repeat the same laryngoscopic technique which was done during the failed first attempt. If anything has to change. Okay, and we advocate only performing one extra laryngoscopy because like I mentioned earlier, that more and more repeated attempts at airway instrumentation worsens the airway edema and increases the resistance to breathing, and the child will have an extremely difficult time in the postoperative period because of upper airway edema, right? So you don't want to make a existing difficult airway more difficult and having a child who's finding it difficult to breathe with a stridorous stridorous sound during breathing. Yeah, so these are some of the techniques that need to be kept in mind. At all laryngoscopic attempts, the depth of anesthesia needs to be maintained, and the endotracheal intubation needs to be confirmed with capnography like any other patient. If the laryngoscopy attempt fails, then you need to resume mask ventilation with 100% oxygen. Now, what is different in laryngoscopy in children? You can either use a Miller blade, a Macintosh blade, or a video laryngoscope. Now, there is something called as external laryngeal manipulation, which is in infants and a little smaller children. The little finger or the ring finger of the hand holding the laryngoscope can be used to give external laryngeal manipulation, or there is something that is known as bimanual laryngoscopy, which is described in children, that the person performing the laryngoscopy gives the burp or the external laryngeal manipulation and gets the glottis into view, and another person intubates. So when you have this is known as bimanual laryngoscopy. Again, with the advent of video laryngoscopes and screens, this has become much easier because you can see what is happening on the video screen. Again, you have an entire armamentarium of airway laryngoscopes and devices. You can have Macintosh blade, the Miller blade. You can have the Oxyport laryngoscope, which has an oxygen source during the laryngoscopy to give oxygen. Stillets and pediatric frovas and bougies are available in specialized sizes. So bougies are available in 5, 8, and 11 French for respective age groups and respective sizes of endotracheal tubes. So this is what is different in children. Again, you have an entire armamentarium of video laryngoscopes, especially for children. You have the CMAC blades, one number, 2 number, and 0 number CMAC blade. Okay, the Miller blades of CMAC and the CMAC D blade in pediatrics, which can be used for video laryngoscopic intubation. The pediatric glide scopes are used. TrueView, like I mentioned earlier, has an oxygen source that prevents fogging and gives apneic oxygenation during the laryngoscopy. And AirTrack sizes 0 and 1 with a channel channel through which an endotracheal tube can be used is also available for the pediatric population. Again, when performing laryngoscopy, like I mentioned earlier, the chances of airway trauma are very high. So this is in general for any adult or pediatric age group. When you are performing a video laryngoscopy, there is a 4M rule that first you look at the oral cavity, the mouth monitor. When you are inserting the video laryngoscope, you look at the oral cavity and you insert the video laryngoscope under vision, not looking at the screen initially. you look inside the oral cavity and gradually introduce the video laryngoscope. Second is you look at the monitor. After the video laryngoscope is inside the oral cavity, you look at the monitor and get the glottis into view. Then when you're passing the endotracheal tube, you look at the oral cavity so that you're not blindly advancing the endotracheal tube. And again, you look at the monitor after the tip of the endotracheal tube enters the posterior oropharynx, and you advance the endotracheal tube into the glottis. Applied advancement of the video laryngoscope or endotracheal tube into the oral cavity with a rigid stillet and focusing only on the monitor has led to pharyngeal perforations. So this is more so in children, that you can have bleeding, trauma, and upper airway injury. So that's not very something that you would want to have with a patient you're dealing with, right? Coming to step 2, when you have the failed first attempt at laryngoscopy or video laryngoscopy, you resume face mask ventilation. So that stresses the importance of, again, resuming face mask ventilation with 100% oxygen, so that the ventilation continues and you do not have desaturation during insertion of a supraglottic airway device. At each step, you continue nasal oxygen. Again, the importance laid on oxygen, and keep the upper airway patent and attempt mass ventilation. We advocate using second generation supraglottic devices, more so in children. Like I mentioned earlier, if you cause stomach insufflation, you can use the drain tube of the supraglottic airway device to pass a nasogastric tube, decompress the stomach, and prevent diaphragmatic splinting, so that your saturation improves further because your lung capacity improves. And any subsequent attempt has to be done only if the saturation is more than 95%. Resume mask ventilation between attempts. If a particular supraglottic device is not fitting properly or there is inadequate seal, you can change the type of supraglottic airway device or change the size of the supraglottic device. There are some studies which recommend using a higher size rather than lower size of supraglottic airway device, and deflating and inflating the cuff a little less. Okay, maintain adequate depth of anesthesia during any airway instrumentation. If this is successful, wake up the child. If you are unable to proceed with securing the airway and it demands having an endotracheal intubation tube in place, or you can continue with a supraglottic device in place, or pass a fiber optic intubation through the supraglottic device only if it is needed, and tracheostomy if the situation demands. Coming to the third step, the supraglottic devices, the entire spectrum of supraglottic devices that are available in children are ProSeal, the iGel, the Ambu Aura Gain, the Ambu laryngeal mask, the AirQ. So we advocate inserting the second generation supraglottic device, okay, because like I mentioned, the drain tube can be used to insert the nasogastric tube and decompress the stomach. Coming to step 3, again, reinforcing the nasal oxygen and oxygenation with the rescue face mask ventilation. Here we've mentioned that consider insertion of the gastric tube to decompress the stomach, and continue face mask ventilation using oral nasal airways. And if you are successful with rescue face mask ventilation, wake up the child. If unsuccessful, declare complete ventilation failure and call for additional help. Now, why am I coming to this? Is because there are different techniques of oxygenation through the emergency surgical airway access, which are different in children. So emergency cricothyrotomy is the technique through which you have to give oxygen in an adult. But in children, there are some things which are completely different. You continue attempts at face mask ventilation when you are dealing with a situation like this. Maintain patency of the upper airway and give oxygen through the upper airway. Continue nasal oxygen. Call for additional help. And proceed with emergency surgical airway. Do not wait for the child to begin desaturating. So this is what is different in the pediatric age group, that you continue nasal oxygen and efforts at rescue face mask ventilation through the upper airway. And if the child is less than 8 years and surgical help is available, tracheostomy is the technique of choice. So oxygen has to continue through the upper airway, and you can use nasal prongs. And surgical tracheostomy is the technique of choice if help is available. But if surgical help is not available, and the child is less than 5 years, you do a transtracheal needle puncture, which I will come to in a minute. Okay. And if the child is between 5 to 7 years, you do a needle cricothyrotomy. And if the child is more than 8 years, irrespective of the fact whether surgical help is available or not, a needle cricothyrotomy with pressure regulated jet ventilation device is the technique of choice. So I mentioned earlier in my earlier slide that you do a transtracheal needle puncture or a needle cricothyrotomy in children. So why is this? Because there have been review articles in literature where they have done cadaveric studies, and they have studied confidential inquiry into perioperative deaths, and they found that cricothyroid puncture in young children, which is recommended for emergency surgical airway, is fraught with danger, as the anatomy is a lot different, right? So you have the larynx, which is much higher, so it is difficult to palpate the larynx. There is a lot of adipose tissue in the neck. The dimensions of the cricothyroid membrane are very small. Okay, and the angulation of the cricothyroid membrane is such that when you do a cricothyrotomy, the cannula can go cranially rather than caudally, and the oxygen can escape through the upper airway rather than insufflating the lungs. That is why it is recommended that in children less than 5 years of age, rather than performing a cricothyrotomy, you do a transtracheal needle puncture. So these are some of the reasons why a transtracheal needle puncture is preferred. Okay, so this is what I was telling you, that the larynx is conical in smaller children, whereas it is cylindrical after 5 years of age, and that is why you can do a needle cricothyrotomy in children more than 5 years of age, but less than 5 years, you need to do a transtracheal, that is at the level of the tracheal rings, maybe approximately 2 finger breadths above the suprasternal notch. So surgical tracheostomy in less than 8 years is the procedure of choice. And more if surgical help is not available, less than 5 years, transtracheal puncture, more between 5 and 7 years, or more than 8 years, needle cricothyrotomy using a pressure regulated jet ventilation device. Now, when you're using a pressure regulated jet ventilation device, this is something different in children that you need to take care of. That the upper airway has to be kept patent for expiration to occur through the upper airway. Okay, surgical cricothyrotomy, a cannula cricothyrotomy are not recommended in children less than 12 years of age. And whenever you're doing a cricothyrotomy, a surgical tracheostomy should be done as soon as possible and as soon as help is available in less than 40 minutes following a cricothyrotomy. Otherwise, it can cause damage. Children can develop pneumothorax, subcutaneous emphysema, the cannula can dislodge. There are multiple complications in children. Now, coming to the oxygen delivery through the high frequency, through the jet ventilation, pressure regulated jet ventilation device, this is a ManuJet, and this is a Sanders jet injector. So when you do a transtracheal needle puncture or a needle cricothyrotomy in children, you attach this through the central wall unit, okay, with an intermediate to intermediate pressure system. And this is a pressure regulation device. So you open this pressure regulator and begin with, this is calibrated from 0 bar to 4 bar, that is 0 to 60 psi. So you begin with 0.5 bar, okay, and take care that the cannula is inside the trachea by confirming with free aspiration of air. So it should not be in a false plane, and you have to fix it well so that it does not get dislodged with this high pressure regulated jet ventilation device. Otherwise, you can have your needle getting dislodged and the child developing subcutaneous emphysema. So when you are giving oxygen through this pressure regulated jet ventilation device, you open this trigger and fix the pressure at 0.5 bar. Continue ventilation through the upper airway if whatever little oxygen can go, and you will perform this only when you cannot ventilate, obviously. If the child can be ventilated through the upper airway, the need for cricothyrotomy does not arise. Okay, but whatever rescue attempts at face mask ventilation can be attempted, you continue that through the upper airway with 100% oxygen, and you connect this with a lure lock connector to the needle, transtracheal needle puncture or a cannula cricothyrotomy. Begin with the lowest pressure of 0.5 bar and give 1 second of inspiration through either the ManuJet or the Sanders jet injector, and give adequate time of 4 seconds. So the inspiratory-expiratory ratio has to be maintained as 1:4 to give oxygen and to allow adequate expiration to occur, because expiration is a passive process and will take place through the upper airway. If you do not stick to this inspiratory-expiratory ratio, you can cause barotrauma in a lung and child lung, and it is extremely easy to cause pneumothorax in a child. So you begin with the lowest pressure so that you see a visible chest rise. The upper airway patency has to be maintained, and the inspiratory-expiratory ratio has to be maintained as 1:4. Again, that was about the laryngoscopy, the supraglottic device, the rescue face mask ventilation, the mask ventilation technique, and the emergency surgical airway access, which was different in pediatrics. Coming to fiber optic intubation and bronchoscopy in children. So general in fiber optic intubation, difficult airways is that you continue oxygenation and deep inhalational anesthesia through the upper airway, topicalize the airway well, plan for the airway strategy, and consider availability of all the necessary equipment. Have skilled assistance with another person monitoring the fiber optic, the vital parameters of the child when the person performing the airway instrumentation is busy with the airway. Another person should be monitoring the child and have a backup plan ready. So these are the strategies how you will perform fiber optic intubation in children. There are various techniques that are described. You have a self-sealing mask with a diaphragm. So you continue mask ventilation during the fiber optic technique, and through the self-sealing diaphragm, you can perform the fiber optic technique. Or you can have the nasal trumpet, like I mentioned earlier, and you attach a JR circuit or a closed circuit to this with inhalational agent, okay, so that the depth of the anesthetic is maintained, and through the other nostril, you can perform the fiber optic intubation with the adequate size of fiber optic scope and with the endotracheal tube railroaded over it. Or the third technique is you can use a supraglottic device through which a fiber optic intubation, so oxygenation can continue during the fiber optic intubation. Again, when you're performing fiber optic intubation through a supraglottic airway device, endotracheal intubation can be performed through the supraglottic device by railroading an endotracheal tube, two endotracheal tubes, so that the length of the endotracheal tube is obtained. Or you can put a guide wire through the working channel and railroad an endotracheal tube after removing the supraglottic device. Or in an older child, you can use an entry exchange catheter over the fiber optic scope. Again, coming to cuffed tubes and uncuffed tubes in children. So uncuffed tubes were very common in children less than 6 years. When we used to be residents, we used to use uncuffed tubes, but not anymore, because what has changed is this microcuff pediatric tubes with micro thin polyurethane material is available, and they are high volume, low pressure cuff. So the number of endotracheal tube exchanges, the oxygenation, the tidal volume delivery, the leak around the endotracheal tube has significantly reduced after using microcuff tubes. The sealing pressure is much below the presumed capillary perfusion pressure in the pediatric population, as a result of which the ventilation is a lot better. Now, what is different in these microcuff tubes is that there is no Murphy's eye, okay, and the distance between the tip of the endotracheal tube and the microcuff is minimal. So the chances of your cuff being beyond the vocal cords and the tip of the endotracheal tube being endobronchial are minimized. If the disparity or the distance between the tip of the endotracheal tube with a Murphy's eye here and the cuff is too much, then the cuff will be beyond the cords and the tip will be endobronchial, okay, because the margin is relatively less. That is why we have these special microcuff tubes which have changed the way we practice intubation in children. So this is the original article in which they've compared cuffed and uncuffed tubes, and it was published in Anesthesia in 2018. And the significant salient features of this were that cuffed tracheal tubes were associated with lower leaks, higher tidal volume deliveries, and more stable ventilation parameters. Children intubated with cuffed endotracheal tubes show lesser adverse events, sore throats, and hoarseness. And cuffed endotracheal tubes or microcuff tubes are associated with superior outcomes when compared to uncuffed tracheal tubes in children. So I think with that, I end my talk, and we are open to discussion and questions from the audience. Thank you very much.
Thank you so much, sir. Thank you so much for the interesting session. Madam, over to you, ma'am. Or Sweta, if there are questions from the Q&A, can you just post it here also?
I couldn't see any questions. Shweta, are there any questions?
No, ma'am.
Okay. Thank you very much. And the topics were so well covered. Rakesh, if there are any questions that you think or anything you want to clarify, the only thing that I wanted to stress upon was this, the new things that we have talked about, the Thrive and the high flow nasal oxygen, because of course, from the exam point of view, students might have learned, but very few have seen them. So truly speaking, these points were very, very important. And so also the oxygen cascade and the oxygen flux, which we very often ask the students. Just wanted to know from Dr. Jensen. Thank you so much, Dr. Jensen. Do you have any of these, the difficult airway card that you said for the pediatric this thing population? Do you have a separate one which is readily available?
Madam, you have to have different equipment that is to be procured. So the Cook airway exchange catheter or stillet, the video laryngoscopes. So pediatric sizes have to be specially asked for, and you have to have your own cart ready. It's individually, there are different vendors who are dealing with all these different equipment, and you need to have all of these if you're a patient dealing with a special patient subpopulation.
Very true. And so also Manujet that you talked about.
Correct.
Have
That's
you,
the VPM and the Sanders jet injection.
Yeah. Do you have that with you in your center?
Yes, ma'am.
Yes, sir. So do we. And of course, it's very, very, to have these, sometimes the jet ventilation, otherwise from the other ones may not be available. But this is a very, not very new, but relatively new, which has been available, which is helping a lot. Correct. And that's true. And what about the cricothyrotomy sets?
So we use, for adults, we use the Cook-Melker set. And the Manujet comes with a specialized Rabusen needle, which is a Teflon needle, which is non-kinkable. So the problem with usually using these cricothyrotomy sets is that the cannula can get kinked or can get dislodged. So these special cricothyrotomy needles that are available, they are made up of special material so that it does not get caught into the between the cartilages and does not get kinked. Because if it gets kinked, then or it gets dislodged, then there's a chance of subcutaneous emphysema and the high oxygen force not going into a correct place. Okay, so it doesn't serve the purpose. So these specialized needles are available, and they're different for infants, children, and for adults. So there are 3 sizes available of these Rabusen needle, and there are multiple cannula cricothyrotomy sets like the Quick Track, the PCK, the Perk Track, which are available. And apart from that, the surgical cricothyrotomy that has been recommended, that is the scalpel, the bougie, and the endotracheal tube, that we specially have it in a Ziploc with a 10-number blade, with a bougie, and with a 6-number endotracheal tube that is kept ready in all anesthesia sites where difficult airway cart is needed.
Right. Rakesh, like you do a lot of simulations. So do you have this also in your armamentarium when you're doing simulation sessions in the conferences, so that the children, really students, learn?
Yeah, ma'am. For the purpose of surgical airway, we use 2 types of models. I think this is a good one, which Dr. Jason has emphasized also. For the adult patients, we have both the aspect, one is the commercial tools that he mentioned. The other commonly used technique is the stab blade bougie tube technique, where you just use the gum elastic bougie that is available with us and an 11 size blade, and usually go ahead with size 6 millimeter internal diameter tube as the standard technique. And this is an acceptable surgical cricothyrotomy set, which does not require any sophisticated gadgets, and this is found to be useful. We can always learn, and many people are listening, so you can use the goat trachea, or there are also the commercial task trainers which are available for it, and it can be easily done. You just do it 5 to 10 on these, and it is the learning curve is very, very narrow for this. So 5 to 10 is sufficient for you to learn.
Yeah, so I think that's very important that in our simulations we must do these things so that they actually know how to. Otherwise we have everything, but we really don't know how to practice it. And Rakesh, as you were telling us about the hyperbaric oxygen that you saw in RML, just wanted to know that which other places in Delhi would be having this oxygen hyperbaric chambers? I think nowadays.
So it is with the Apollo Hospital, where they have a multi-place chamber. At RML, they have mono-place chamber, 2 in number. Yes. And even at AFMC Pune, they are using it. And probably AIMS will soon be having one of the chambers available. And we have done a couple of studies at that time where we have used it for the head injuries as well as osteoradionecrosis, even for diabetic chronic wounds. And the recovery for these patients was much better. There was improvement in GCS patient with head injury. There was improvement in the wound score. There was improvement in the osteoradionecrosis, where they have found a very important role and should be used for these
Right.
type of pathologies.
So since now, as you said, Apollo has it, just a little advice I'd like to ask you. Do you think Gangaram should purchase one? Because people are now approaching us. So I wasn't really sure, whether, the space they occupy and whether it was really financially viable.
But I understand, ma'am, because the maintenance is not too high. And because at RML, when I was working, I was also looking after. So it's easily doable with a technician and a resident. And we could easily do 8 to 10 cases every day, because each session will be for around 45 minutes to 1 hour. So we can cover it, madam. So I think it's very useful for these things. And your center being a high volume onco center also. So you will be getting a lot of head and neck radiations with osteoradionecrosis and malignant wounds. It will be a useful tool, madam.
Very true. We'll take your advice then.
Thank you, madam. Thank you.
Dr. Radhakrishnan, I see you there. Are there any questions that you'd like to add before we conclude? Anything else?
I don't have any questions to Ragesh or to Jason. And the session was excellent.
That's right. Very true.
One of the very few sessions which is really stimulating to go to the very end. Yeah. Good. Thank you, Jason. Thank you, Ragesh.
Yes.
Thank you, sir. Thank you.
Yes. The basics were so well covered, so important.
Well covered, very well covered.
Yes, starting. Because sometimes when we ask the students the cascade and oxygen flux, they just
I must say, the best we had with the oxygen so far.
Yes. And all the therapy devices. Thank you so much, Dr. Rakesh and Dr. Jensen. And yes. Thank you. And we meet next Wednesday at 7 o'clock. Thank you so much. Good night. Thank you, Shweta.
Thank you, ma'am.
Thank you, ma'am.
Sanish could not be there, but a big thanks to him as well.
Thank you.
Thank you.
Bye-bye.
Bye, ma'am.